So hello and welcome to this medical emergency podcast on pulmonary edema. During this podcast, I'm going to cover the definition of pulmonary edema, its causes, presentations, important investigations, and finally, its emergency treatment. So, acute pulmonary edema is a common and life-threatening emergency that is characterized by the accumulation of fluid within the interstitium of the lungs. It is common in the hospital setting and as such, something that as a junior doctor you should get to grips with early. So first, let's go through the most important causes of pulmonary edema. Pulmonary edema is sometimes referred to as acute left ventricular failure, and this is because edema tends to occur in patients with known cardiovascular disease. Previous MIs would be a good example. However, usually such patients require an additional insult to push them over the edge. Let's go through these insults now. The most common cause of acute left ventricular failure is probably iatrogenic, i.e. of medical origin. The culprit here being the overenthusiastic use of intravenous fluids. For this reason, it is always important to consider a patient's age and comorbidities before deciding the volume and rate at which you administer fluids. Probably the next most common cause or set of causes are new cardiac events, including ischemia, ventricular or supraventricular arrhythmias, new valvular lesions, and highly elevated blood pressure. Infection is another important cause, particularly pulmonary infection, which is often a contributing factor to severe pulmonary edema in the elderly. Lastly, pulmonary edema can occur in the setting of trauma, particularly head trauma. This is part of what is known as the adult respiratory distress syndrome. Presentations of pulmonary edema can vary, but most commonly, patients become acutely distressed with sudden onset of breathlessness, sometimes together with the production of pink, frothy sputum. On examination, there are three characteristic things to look for. These are bibasal crepitations, a gallop rhythm, that's S3 and S4, and signs of excessive adrenergic activation or diaphoresis. Examples of these are pallor, sweating, tachycardia, and tachypnea. Often, pulmonary edema is a diagnosis that can and should be made clinically, but investigations may be needed to provide further proof of your suspected diagnosis and to establish an underlying cause. Ideally, however, you would wish to begin treatment before starting extensive investigations. I'm therefore going to talk about emergency treatment before important investigations. From a basic point of view, we can consider the management of pulmonary edema just like any other emergency. So, you manage with respect to A, B, C, that is airway, breathing, and circulation. For airway, there is usually not much to do, but it's important to assess it and bear in mind that a patient may need some type of airway support if they have a particularly low GCS or are comatose. In terms of breathing, you must sit the patient up and give 100% oxygen. This is even the case if the patient has COPD. Remember that hypoxia kills quicker than hypercapnia. For circulation, you wish, of course, to gain good IV access. You then want to give some drugs, specifically diamorphine, usually 5 mg, but do use 2.5 mg if the patient is particularly old or frail. This should, of course, be given together with an antiemetic. The one I usually think of is 10 mg of IV metoclopramide. The morphine is good because not only does it relieve some of the anxiety associated with acute pulmonary edema, but it also causes a degree of vasodilatation within the vessels of the lung. Please note that you should not give cyclizine in this situation, as this antiemetic can actually worsen left ventricular function. Next, you want to give 40 to 80 mg of furosemide IV. This produces two effects: an immediate vasodilatation, just like the morphine, that leads to a reduction in preload, and then obviously later, a diuretic effect that can also be useful. Provided the blood pressure is not less than 90 systolic, you might also consider giving GTN, either as spray or more usually as an infusion. Most patients should stabilize with this basic regime of treatment, and you should most certainly have called for senior help by the time you've given all of these. If, however, the patient does not respond or indeed worsens, you may wish to consider the need for non-invasive ventilation, i.e. CPAP, and if the patient is hypotensive, ionotropes such as dobutamine can be used. However, don't give these yourself. The patient will most probably require ITU admission prior to starting these therapies. If you wish to know more about these drugs, I recommend listening to the first part of one of the clinical pharmacology and therapeutics podcasts on cardiac failure. This can be found on the website, that's podmedics.com. Now you have a stable patient, you'll want to investigate for the cause or the insult that led to the precipitation of acute left ventricular failure. You'll certainly want to do some bloods, both arterial and venous. You'll probably do quite a few venous bloods, but specifically you'd be interested in infectious markers such as white cell count and C-reactive protein, and also cardiac enzymes, for example, the troponins. In terms of imaging, the most important initial investigation would be a chest X-ray, and here you would obviously be looking for characteristic signs. There are 4 important signs to be aware of on a chest X-ray. These include cardiomegaly, curly B lines seen at the periphery of the lung due to interstitial edema, bat's wing shadowing, otherwise known as bilateral perihilar haziness due to alveolar fluid, and upper lobe diversion due to distension of upper lobe lung veins. You should almost certainly also do an ECG to look for signs of ischemia or arrhythmias that might have precipitated the failure. It's also prudent to eventually do an echo to check the ejection fraction and look for any acute or chronic problems with the valves. So, in summary, acute severe pulmonary edema is a life-threatening and often severely distressing emergency. It usually affects patients with known cardiovascular pathology, and common precipitants include overzealous fluid replacement, ischemic events, and arrhythmias such as atrial fibrillation. It presents, as you might expect, with the signs and symptoms attributable to lung congestion together with severe adrenergic activation. Treatment should begin together with, or ideally before, investigation, and most importantly includes sitting the patient up, supporting them with high-flow oxygen, and giving various drugs. The most important drugs to remember are morphine, furosemide, and GTN. However, patients may need further specialist involvement and treatments if they do not improve with these simple measures. So that completes this quick run-through of severe pulmonary edema. Thanks for listening, and see you soon.